Hi, today we're going to be talking about the pathology of blood incompatibilities. The first one we're going to talk about is your Rh factor. What is the Rh factor? Also known as the rhesus factor. These are proteins that are found on the surface of a red blood cell. If you have them, you're considered Rh positive, and if you don't, you're considered Rh negative. People with Rh positive blood can receive Rh positive and Rh negative, whereas people with Rh negative factors can only receive Rh negative. So in relation to incompatibility, this occurs when you have an Rh negative mom and an Rh positive baby. The mom's blood will meet the baby's at some point, but this doesn't often happen in utero. But when that happens, the mom will then create antibodies and then be able to fight against the Rh positive blood in the future. This is rarely an issue for the first child, as there are not very many ways for mom and baby's blood to mix in utero. The couple of them being trauma, a rupture placenta, and an invasive procedure like an amniocentesis, which is why blood typing is always done before an invasive procedure. So during delivery, mom is going to deliver this baby, their blood is going to mix at that point. Now mom is going to start creating the antibodies against Rh positive blood. But at this point, the baby's already going to be out and delivered, so that she won't have time to really fight against it at that point. So this is really an issue for the second baby, because now your mom has these antibodies built up already for this baby while it's already continuing to grow. How can we prevent this? So you can get blood testing done, and this always happens at your first prenatal visit. It's called an indirect Coombs test, and it's testing to determine if you have antibodies on your red blood cells. As a mother's first prenatal visit, this will be done to determine your rhesus factor. If you're Rh positive, then you're fine. Nothing will be done, because we know that you can receive positive and negative if you're Rh positive. But if you're Rh negative, then they're going to give you a shot called Rogam that's going to prevent you from creating those antibodies in the first place. You'll receive one shot at 28 weeks, and then after delivery, they'll test the baby, and if that baby is Rh positive, then mom will receive another Rogam shot within 72 hours after delivery. Interesting to note though, if you already have antibodies for whatever reason towards Rh positive, then the Rogam shot will not be effective for you. All right, so what happens if it's not treated? So an interesting thing happens in utero where mom and baby's blood doesn't mix, but mom is still passing on her antibodies in a process called passive immunity. So your antibodies are being able to pass through, and now those antibodies against Rh positive blood are going in as well. So then if you have antibodies that are going to fight Rh positive blood and your baby is Rh positive, then it's going to start breaking down those red blood cells that those factors are found on in a process called hemolysis. Now, a couple of things are going to happen in a domino effect after this. So if you are breaking down your red blood cells, then you're going to be severely anemic. Another thing that we know about red blood cells is that they carry oxygen. If you're lacking in oxygen, you're not going to be perfusing well, then your heart is going to be working in overtime in order to compensate for this. You're going to put your infant into heart failure. Another thing that's going to happen is you're going to have generalized edema in the whole fetus, as well as swelling in the liver and the spleen. Now, what we know is that red blood cells, when they're broken down, they create some waste products, one of those being bilirubin. Now, we know that bilirubin is processed in the liver, but when you have overloads of bilirubin, the liver can't keep up with the processing. So you have this unconjugated bilirubin just floating around, and that's what's causing your jaundice, a lot of jaundice in these infants. Well, another thing we know about bilirubin is that bilirubin is a neurotoxin. So it's going to start to build up throughout the body and it eventually get to the brain. And increased levels of bilirubin in the brain can cause neural defects and long-term brain development. The other type of blood incompatibility we're going to talk about is ABO incompatibility. This can have the same unwanted effects as Rh factors, but it's usually not nearly as serious. This is more common though. So similar to the pathology of the Rh factor, your blood typing is determined by the protein found on the outside of your red blood cells. So you can have A, B, or O, and that's all determined based on the protein that's found on that red blood cell. Unlike the Rh factor, there's no initial exposure required in order for you to create these antibodies. You're already born with the antibodies that are going to be fighting other blood types that aren't yours. The good news, however, is that these antibodies are usually much lazier than the Rh factor and aren't typically as aggressive. So you can have ABO incompatibilities without having any symptoms at all the way up until you can have some with more severe symptoms that we'll talk about in a minute. So typically your blood typing is done when you're getting that Coombs test at your initial prenatal visiting. And then after the baby is born, they'll also do a blood type on that baby as well. And as we know that as the antibodies are going to be attacking the red blood cells, they can cause some anemia and some breakdown with an increased chance of bilirubin, which is going to be causing the jaundice. This is not likely to cause as the severity as it would with the RH factor. Assessing newborn for jaundice is a high priority, and you'll do this by just gently pressing on the baby's forehead and nose, and if when you remove your finger there's a yellow spot, that's considered mild jaundice, and if you're looking in the baby's eyes and there is severe yellowing of the sclera, it's considered a more aggressive type of jaundice.
Hi, my name is Dana. I'm going to be your nurse today, okay?
Okay.
I do have a couple of questions for you. Just state your name and your birthday for me.
Lily Perez, April 16, 1999.
Awesome. And how are you feeling today?
I'm feeling okay.
You're feeling okay? Alright, so I do want to talk to you about a couple of things. I know the nurse previously mentioned that you have a blood incompatibility, and you actually have the RH incompatibility instead of the ABO incompatibility. Do you know what that is exactly?
No, I don't.
No? Okay. So the RH, you actually have RH negative in your blood, and the baby has an RH positive. And that just means your body is actually building antibodies against the RH positive on the baby. So meaning that can actually harm the baby. Is there anything verbally you want to voice out about the concern and fears you're having? I know it is a very scary topic to talk about, but it's good to let things out.
Will we be okay?
Yeah, you're going to be great. We're going to be doing some management. We're going to actually give you some, I'm going to explain some steps and procedures that we're going to be doing. First, actually, before your pregnancy is up, so 3 months before your pregnancy is done, we're actually going to give you a dose of Rogaine, and that just helps prevent the buildup of antibodies towards the baby. And you're going to have another dose during labor and delivery. And then after the baby is delivered, we're going to actually give you another dose.
Okay.
Once the baby is delivered, we're going to be checking the babies very thoroughly, okay? And the baby does have, shows a little bit of yellow skin. We're just going to be putting baby under phototherapy, and the phototherapy is just under a blue light that's actually going to help prevent the buildup of red blood cells in the baby system. Also, we're going to encourage breastfeeding if that is how you want to feed the baby. It just helps a lot with the baby and its growing factors, and it helps build up the baby's immunity also. We're also going to maintain the baby's blood temperature so that way he can be healthy and good for you guys to go home, okay?
Yeah, okay.
Do you have any concerns right now?
No, I'm good. You explained everything. Thank you.
Sounds good. You're welcome. If you need anything, just call. I'll be here. If you have any more questions, if anything pops up in your head, just let me know. I'll be more than happy to explain things for you, okay?
Okay, thank you.
All right, have a great day, okay?
Okay, you too. Thank you.
Hello, I'm Jerica. I'm going to be your nurse today, and what we're going to be doing is I'm going to be obtaining a health history. We're also going to be doing a blood typing as well as an indirect Coombs testing on you today.
And what's that second one?
Well, for the blood typing, what that's going to do is it's going to let us know if you're A, AB, B, or an O blood type, as well as whether or not you're a positive or a negative blood type. And the indirect Coombs testing is actually to screen for antibodies, because if you've had any previous pregnancies before, it's going to let us know if you've built up those antibodies against the fetus.
Okay.
Now, if your indirect Coombs testing comes back negative, meaning that there are no antibodies present and you are a negative rhesus factor, you're actually a prime candidate for Rogaine. And what that's going to do is Rogaine is really, it just prevents your system from attacking that of the fetuses if they were to be a positive blood type while you are a negative blood type. However, if the indirect Coombs testing comes back positive, there is no value in doing a Rogaine. However, we would still monitor the fetus for hemolytic diseases. And you'll receive the first shot of Rogaine at 28 weeks, and you'll also receive the second shot within 72 hours of giving birth, so long as the fetus is a positive blood type. If they're a negative blood type, there's no point in actually doing a second shot.
Oh, good. Okay.
But it's going to be an IM injection, so it can actually be in your arm or along your backside, and it's going to be 300 micrograms. And I will just need to witness your signature of consent that we can do all the blood type and indirect Coombs testing for you today.
Yeah, of course.
Excellent. I'm also going to be assessing your vital signs as well as the fetal heart rate every 15 minutes for 1 hour after I do the administration.
Okay.
I'm also going to be observing your puncture site for bleeding as well as drainage. And just when you get discharged to go home, we just ask if you develop a fever, have leaking amniotic fluid, vaginal bleeding, or uterine contractions, or if there's any increase or decrease in fetal activity, that you immediately notify your provider.
Okay.
All right, I'll go grab the paperwork and we'll get started.
Okay. Thank you.